So MRD is a really interesting topic, and it is somewhat fraught with difficulties because there is still limited data in terms of how to approach MRD in a clinical setting. There is a number of MRD tests out there, but the two most commonly used tests would be either flow cytometry-based MRD, which detects CLL cells at 10 to the minus 4 level, so basically 1 in 10,000. The more novel approach, but also more expensive and even less available, is next generation sequencing MRD, which detects 10 to the minus 6 level, which is 1 in a million cells. So that assay is commercially available. The issue, however, is not only fairly limited availability of both of these assays in the United States and Europe, only a limited number of labs can do them, but also there is so far no clinical trial data which inform us what exactly we need to do once we detect a positive or negative MRD level. We know that in the era of chemoimmunotherapy, MRD and achievement of an undetectable MRD is predictive of progression-free survival and overall survival also. Now with novel targeted agents, the data is emerging. As you know, with venetoclax-obinutuzumab combination, patients who achieve undetectable MRD level have better progression-free survival compared to patients who don't. However, what we don't know, for example, in that setting with venetoclax CD20 combination, is whether continuing venetoclax in patients who do not achieve undetectable MRD is associated with additional benefit. So such studies, which are MRD tailored studies, are ongoing, and hopefully we'll know more in the future. And then, of course, we have BTK inhibitors, which do not reach MRD as single agents, but they are very effective. So the field of MRD is evolving, and we just need more clinical trial results to better determine how to use MRD in everyday clinical practice. For myself, I actually don't use MRD testing outside of clinical trials, except for some special situations in my patients.